Welcome to the PCOS Fertility Health Podcast. I am your host, Dr. Angela Potter. I'm the creator of the PCOS Fertility Protocol, and I work with women around the country to help them optimize their fertility with PCOS. And I am overjoyed to have a fellow colleague on the podcast today. Dr. Aumatma is a naturopathic doctor and board-certified fellow of naturopathic endocrinology. And she is an award-winning speaker on women's health and fertility. And she is the creator of the Restorative Fertility System, which is a 4-step process to improving fertility and empowering couples to have a healthy baby. Her and I are covering recurrent pregnancy loss. So if you are in that space where you have been able to get pregnant, but you have had a miscarriage, if you've had one or a few, this is going to be a really important episode for you. We talk about what causes recurrent pregnancy loss, misconceptions about pregnancy loss, and we cover what needs to happen if you're working with a doctor who says, well, you need to go through 3 pregnancy losses before we can do any more workup for you. We also cover a little bit about age and infertility. So this is going to be a very important episode for you if you've been told that age is keeping you from getting pregnant, or if you've been told that, I'm sorry, we can't help you until you have 3 pregnancy losses. This episode is going to help you understand what kind of help is available and how you can be supporting your body to get this optimal, fertile environment in your body. And before we dive into that interview, I want to be sure that you are joining the fun over on Instagram. Find me at Dr. Angela Potter. I share common PCOS misconceptions, ovulation tips, information about periods, and overall just optimizing fertility health with PCOS. So be sure you are joining the party over on Instagram. And if you are loving this podcast, please head on over to Apple Podcasts and give me a positive review. That helps other women who are looking for this information to be able to find it. And I just want to acknowledge you for showing up here today because there are so many podcasts out there, but you are choosing this one. You are choosing to flood your brain with fertility information that is going to support your PCOS, help you put together these PCOS pieces, and get the best chance that you can at getting pregnant. And even though you have been trying to get pregnant for the past 6 years, you know that the answers that you've gotten so far, like, well, your labs look fine, so just come back when you're ready for IVF. You know that that doesn't sit right with you. And so you are on a mission to figure out how to optimize your fertility health. And I think that is really cool. And know that you are in exactly the right place today. Let's dive into my conversation with Dr. Aumatma. Hi, Dr. Aumatma. Thank you so much for joining me here on the PCOS Fertility Health Podcast.
Thanks for having me, Dr. Potter.
Yes, good. So we are going to dive into a really important topic that I haven't covered on the podcast yet, which is recurrent pregnancy loss. And it's, the fertility journey, regardless of what you're experiencing, is really difficult. But with that recurrent pregnancy loss, it's heartbreaking.
Totally. It adds a whole new layer of grief, of trauma, of just emotions that often get pushed to the side because doctors aren't willing to really face it head on and do anything about it until a woman has had 3 losses. So absolutely, such a troubled landscape.
Yes. Yeah, which is why I'm so happy to have you here because I know this is a big part of your fertility expertise. Mm-hmm. So, let's start by talking and sharing with people who are listening, what are some misconceptions about recurrent pregnancy loss?
Well, I think the first one is it's important, or maybe I'll say it a different way. A lot of women feel like it's their fault. Right? They did something that caused a pregnancy loss. So I want to be the first to be nope, that's just not the reality. They did not do anything wrong. Nothing is wrong with them. They're not broken, right? All of the things that I think as a woman, it's normal to go through because as soon as we get pregnant, we get into like the protector mode of this baby, right? So like if something happens to my child, I'm going to feel like I'm responsible. But the reality is there's so many things that are happening that could go awry that contribute to whether or not we have a healthy pregnancy and a healthy baby at the end of that. And some of them are in our control. Even though it's not our fault, I think there's a lot that we could be doing to stack the odds in our favor. And really the landscape of being able to understand how there are so many factors that are contributing to healthy pregnancy. Like when I first learned about the process and how babies are made, and I like literally just bawling on the floor because I'm like, oh my God, so many things can go wrong. Like it's amazing that we have babies on this planet. So just keeping in mind like it's so complex and it's not instantly anybody's fault. And at the same time, I am for empowering women and couples to do something differently. So this whole idea that we have to wait for 3 pregnancy losses before we evaluate is totally ridiculous. It doesn't tell us anything, right? Like if you have one loss or a second loss and then a third loss, like the third loss didn't tell me any more things than the first loss, right? So why are we waiting for 3 losses? I just don't understand.
Which could very well be a good year, year and a half,
Yeah.
depending on how easy it is to get pregnant and how quickly. So that's like setting people back.
Hmm. Yeah, exactly. And I get it, like from the medical perspective, they're thinking, well, the first pregnancy loss may be normal, quote unquote. Like
Hmm.
body's getting used to it, doesn't know how to sustain the hormones, etc. It's like a practice loss.
Which is
But
crazy.
uh, but even at the first loss, if it were me in that position, I'd be like, well, I want to do some basic testing just to know what's happening. And I may not have anything going on. I may not have anything that needs to be addressed, but even the testing would help put my mind at ease to say, hey, there's nothing major blaring in my face, and it's okay if I get pregnant again. The problem is that when women are not getting any reassurance and they're just being told, oh, it's fine, just go get pregnant again, it'll be fine, then by the time the second loss happens, it's a meltdown because it was supposed to be fine. Like you told me the first one was normal and the second one would be fine. So by the time we have a second loss, it's really detrimental to the woman's confidence, the woman's uh like perception of her own body and what she believes is possible. And we have our culture doesn't really process grief very well in any circumstance, but certainly for the grief of the loss of a baby, like that grief is a different type of grief that not a lot of practitioners are equipped to handle. So they're like, it's fine, like don't worry about it. Like what do you mean don't worry about it? Like I'm the one going through this, I'm feeling all these feelings, and you're telling me it's not important for me to look at those feelings. So then we push them down and they usually get stored in our wombs. And the instant we get pregnant again, all that grief surges to the surface and puts our body in fight or flight, which is not conducive to the next pregnancy. So without having dealt with the grief and having dealt with all of the emotions, we're really like setting women up for failure. And it's not uncommon in my practice to have women who have had 1 or 2 losses that are really afraid. They're like, I cannot
Hmm.
go through this again. I need you to make sure that I never go through this again. And of course, like there are no guarantees, but we have done a really good job of being able to make sure that a couple really has processed all of these emotions and done the tangible, like physical side work to ensure that they have the healthiest pregnancy possible. And usually it has led to healthy babies.
So cool. Yeah, so much to dive into with this. And I think what really struck me that you said is that I think a lot of people who are listening, when you said, well, the medical system is just setting these couples up for failure, could be a huge light coming on in their heads. Like, wow, when they have gone through this fertility process and they're feeling dismissed, and then to hear that from a doctor, like, no, the system is setting you up for failure. That's a huge realization. And, of course, so many doctors are continuing to just push people aside and say, well, we have to wait for that third loss.
Mhm.
You taking a different approach with that, can you walk us through what that would look like for someone, even if they are in that mindset of like, oh, I had one loss, I really want to look into more details in my body, or they're at that third loss and they're like, I really have to get working on this. What does that look like to really be supportive of fertility health in that place?
Yeah, I think that our approach with it is really getting to the why. And I know that so many women with recurrent pregnancy loss are told it's unexplained. There's no reason. It's normal, right? Like we've
Yeah.
normalized this idea of loss. And for me, like sure there are times when our body decides like, hey, this is not the healthiest, most viable baby, and we're gonna do something about it. And that's what and triggers the loss. But most of the time, I feel like at least the people that we have worked with, we when we do the analysis, we do like a really thorough understanding of what's happening with this person and this couple that could potentially contribute to not a positive pregnancy outcome. And that evaluation almost always leads to some sort of understanding of, aha, here it is. Here is why this has not went the way that we would expect. And like if that happens in 99% of couples, yeah, I'm inclined to believe that there is some logic to this, right? Like we can, in fact, if we can figure out the why, then we can address it. And no, none of the things that we have found have been impossible, right? Like most of the time, we can do something about the things that we discover. So the common things that keep repeating are, of course, PCOS is really high up on the list of
Mhm.
underlying things that actually, I'm thinking of a patient who that she's probably got a 5 or 6 year old now. So she had come to me with like saying, "No, I don't have PCOS." And I keep looking at her labs and I'm like, you kind of have PCOS. So
Yeah.
so I like worked with her as if. And I didn't tell her that. I was just like, that's fine. I don't need a diagnosis. We're just going to address the things that are happening. And she'd had 2 pregnancy losses. So we worked on all of the things. They ended up getting pregnant. And she was like 8 months pregnant. And she was like, I was cleaning out my house and I'm so sorry. I found a piece of paper that shows that I have a diagnosis of PCOS. And I was cracking up because I was like, yeah, I could have told you that. But she was like so borderline that no one had ever stressed it. No one had ever worked on it.
Mm.
And I was like, it doesn't really matter to me what the diagnosis is, but it was good for her to be like, oh yeah, I totally had this diagnosis. I just completely like denied it, denied. Like, no, it's not
Yeah.
PCOS because I have regular periods. And I'm like, okay,
Right.
whatever you want to believe.
Uh,
So PCOS tends to be a top, and there is evidence that women with PCOS are more likely to have pregnancy loss. So
Mm-hmm.
yes, endometriosis is the next one, and that's another
Mm-hmm.
really big one. Outside of those, it's a little bit nebulous. So of
Yeah.
course there's like genetic anomalies and things like that, which we don't do anything with. We cannot change your genes.
Mm-hmm.
I tell people like, hey, if this is a genetic thing, like we're not a good fit, we can't do anything. But
Yeah.
it's such a small percentage of the population. I want to say it's like 5% of pregnancy losses are related to genetic anomalies. So it's really
Mm-hmm.
low. So then like what is the other, and the biggest chunk of that is unexplained. So
Right.
there are, I believe that there's hormonal things on the female side, of course. Thyroid is a really big one, autoimmune conditions really big. So those are on the female side, like that's our primary stuff. And then there's a like leading amount of evidence that is pointing to vaginal microbiome imbalances that are also contributing to pregnancy losses.
Which
So
is amazing research.
yeah, yeah, it's so cool that we have that. And I will say, so far we've been testing everyone for the last 2 years or so, because we kind of were seeing this pattern that people would come in and we wouldn't test their vaginal microbiome because they didn't have anything that pointed to needing to test the vaginal microbiome. And
Mm-hmm.
the instant we started testing everybody, it was like, oh crap, like you have zero symptoms. You have
Yeah.
never had a yeast infection, no UTIs, like no history that would point us to anything.
Right.
Yet your microbiome is totally out of balance and you have active bacteria that can contribute to pregnancy loss. So it's been really interesting to see what's coming up when we test everyone, and um it's just like blowing things out of the water. So yeah, that one's really
That's
cool.
that's so cool. Because you and I could geek out over these research studies all day long, but for people that are listening who are going through this journey, I love how that connects to what you said a couple minutes ago about how it almost doesn't matter what the diagnosis is. It's about understanding and looking at the body from all these different perspectives and looking at how the systems are connected
Yeah.
that are then affecting fertility or creating that like downstream issue. And so, from you and me, from our perspectives, like that is where the real gold is in
Mhm.
supporting fertility. It's not about having that ICD-10 code saying exactly, of course that's helpful in certain situations, but it's really about looking at the body. And so I think that should be an important sign of hope for you listening, because you don't need to get fit into this one size fits all box of, okay, you have this diagnosis of recurrent pregnancy loss, we don't know what to do for you. Actually, there's so much. And even, getting your vaginal microbiome tested, like who would have thought?
Yeah.
Yeah.
Yeah, exactly.
And so then you go ahead.
Oh, I was going to say, that was all the stuff on the female side.
Yeah.
On the male side, there are actual factors that are connected to recurrent pregnancy loss in the woman. And these are where like my mind was blown, because the assumption in the fertility world has been fertility is primarily a female problem.
Yeah.
Pregnancy outcomes are primarily a female problem.
Hmm.
And uh, if the man has good sperm, we're good. Evidence is actually pointing that things are very different from what we've been made to believe. So there are factors like methylation, for example, is a big one. And we usually, the research suggests it's like the measure of homocysteine, which is a really easy marker. It costs like $10 to test.
Mhm.
And hyperhomocystinemia is connected to recurrent pregnancy loss in the female partner. So hyperhomocystinemia means that homocysteine is high, and that's a really easy thing to find. It's a really easy thing to address, honestly. And if it gets addressed, there's something that's shifting. And like most of the guys we test have great sperm. So they actually like check the box and they have been told like, oh, your sperm are great, everything's fine. And
Mhm.
even per our like very stringent optimal evaluation, we're like, yeah, the sperm are actually really good. Like we're not gonna bug out about those. But then they have one of these underlying factors and we're like, yeah, well, we can't like you cannot get your woman pregnant right now because the factor that you have happening is contributing to whether or not she's going to have a healthy pregnancy. Uh, so a lot of it becomes an equation of really like the guy has to get on board and ensure that he's going to do all of the things that are going to help support a healthy pregnancy outcome before conception.
Yeah. That, I find doing a lot of education about because so many of us are in this mindset of, well, it's probably the woman's fault. Like there's so much more going on in her body.
Mm,
And yet we've got to look at these markers for the men because
yeah,
the research is finding that that's an issue.
yeah, yeah,
Yeah. And but it takes a lot of education for just that for them to come around to wanting to make those changes in their health.
yeah,
Yeah, in
absolutely. It
certain
takes some
cases.
and and like the men are grieving too. So
Yeah,
when they've had a pregnancy loss, we don't often acknowledge the male grief, right? Like, oh, it's
right.
the woman that went through this. But if we pull the guys aside and we just have that conversation with them, they're like, yeah, I don't really have a space to talk about what I'm
Mm,
feeling because, like, it's obviously way more severe for her. And we're like,
mm,
fine, but let's talk about what's happening for you. And once they access that emotional place, and they're like, "Oh, I'm ready to do whatever needs to happen so that we can have a healthy baby. Like, I'm as committed as she is, and if I need to take care of some things, I will." Which
yeah,
is awesome, right? Like, we want
yeah.
men to be that engaged and that ready to commit to the journey just as much as their female partners.
Hmm. Absolutely, because yeah, it's 50-50. Like both of them are contributing
Yes.
here. Yeah.
Yes. Yeah.
So let's also, bring in this big fertility topic of age and fertility. And how much do you see age involved with recurrent pregnancy loss? And also, are there misconceptions about age and fertility?
Yeah, that's a great question. So, yes, there are misconceptions about age.
Hmm.
I am a believer that age is less relevant than what your body and your ovaries think your age is.
Love
And
that.
and there's a way to shift that perspective. So, it's not like you're not always stuck in your chronological age if there's a way to reverse your ovarian or biological age. So, I am a believer that it's possible and that age is less of a issue than we give bandwidth to. Uh, with that said, I also like walk the line very closely because there are women that are in their 40s, like mid 40s, that will say, "Well, I heard you say that age doesn't matter." So I've stopped saying it in that way because I'm like, well, age doesn't matter, but what does matter is what's happening in your body. And
Hmm.
if your ovaries are already perimenopause, menopause, there's not there's very little that I'm going to do to like reverse it and then you suddenly have a child, right?
Hmm.
So I think really keeping it in perspective, like, yes, age is not the relevant factor if we have 48-year-olds that have gotten pregnant. So
So
it's not
cool.
the age. But what is very, very true is if your ovaries don't have eggs anymore, there's not a lot for us to work with. Or
Mhm.
there's a woman right now who has been communicating back and forth, and her FSH is 30 and her LH, oh no, FSH is 50, LH is 30.
Mhm.
And her AMH was 0.03 or something like that. And with her, she's 41. So she's went into this stage early. But for those of you listening, I'm sure you're like, what do those numbers mean? But essentially, like, FSH over 20 is the medical, like, diagnostic criteria for menopause. FSH over 20 plus not having a period for over a year. And she's that person, right? FSH is 50 and
Mhm.
she hasn't had a period. And what's interesting is there are people that have FSH is higher than her. So I had a 43-year-old years ago who had an FSH of 168. She had very irregular menstrual cycles. She technically could have been put in the perimenopause bucket,
Mhm.
but there was one thing that triggered me to be like, her case is different. And that was her LH was like 4. And usually in menopause, perimenopause, like FSH and LH track together. So if they
Mhm.
both increasing together, I'm like, yeah, that's a done deal. Versus her, which was like FSH was crazy high and LH was not. So I asked her, like, did you have any major stress leading up to you, like, where you are now? And she's like, oh my God, like 2 years ago, my father passed away, and then this happened, and then this happened, and then this happened. She's had like 2 years of very high emotional stress. And I was like, oh, well, that's what I think is contributing to your FSH being so high. Let's work on that. Let's work on the emotional things, and let's see if the FSH goes down. And if it goes down into like a positive range, then the likelihood of you having a baby may be possible. Not guaranteeing this, but let's try it out.
Mhm.
And sure enough, her FSH goes down to 11. Um, and she had a baby. And then a year later, she was like, great, I'm ready for another. I was like, okay, let's give it a try again. And she got pregnant again.
Oh.
And so it's like, for most people, she would have been written off. But because
Mhm.
and actually I forgot to mention, her AMH was like 1.2 or something like that. So she still had eggs in her ovaries, presumably. Like,
Mhm.
for sure her antral follicle count was always low, but as we did the work, and as her body healed some of that trauma, she had follicles again. So it it's fascinating, and that age question is always like a very complex analysis, more than like, oh, you can't get pregnant over a certain age. It's like we need to know way more information about you, your body, your periods before we can assess whether or not we're going to be able to help. And there are people that I'm like, I'm sorry, I'm not the best fit, but here are some other people that might be able to help.
Mhm.
So I refer a lot because I feel comfortable, like, really focusing on the people that I know that I can definitely move things forward for, and then the ones that I'm like, I don't know about this. This might be a little tricky. Um, and they can still, some of them I tell like, hey, this can be tricky, and they will still be like, okay, that's fine. We'll still do this. And other people are like, oh, do you have someone else then that you would? And I'm like, happy to put you to someone else. Um, so yeah, so
Yeah.
the age myth is very real. The myth actually came from, not from science, but 1800s France. churches were documenting that women were not bringing their children in to get baptized after the age of 35. And if you think about 1800 France, what
Oh
was
my
happening
gosh.
in the 1800s? Like there was a plague, there was all kinds of things. Like women were dying before 35, very plausibly, yes.
Yeah.
So the fact that we've created the entire fertility system in present day is based on this myth that started in the 1800s that has never actually been proven, right? Like we can't measure ovarian age. We
Right.
can now. There's a cool test that someone is working on. But in like there's not a real like, hey, this is actually your ovarian age. There's no like conclusive evidence, and there's no bodies of research that are actually saying, hey, we compared these different age groups and this is how much of a decline we found. There's not any mass data. There are some countries that are doing that research now. And what they found is that between the ages of 25 and 29 age group and 35 and 39, there's a 3% decline in fertility. So a 3% decline is very different from your fertility drops off of a cliff at 35. And like, I hope that for those of you listening in and are like, if that gives you a little bit of reframe to get out of the fear mode around your fertility, right? Like it's such a interesting landscape to have people just like, oh my God, I'm 36 and I'll never get pregnant. And I'm like, you just turned 36 last month. So did something
Right.
suddenly change?
Right.
And that's kind of how doctors present it, right? Like, oh, you got to
Yeah.
do this before you turn 35. Who cares? Like
Yeah.
2 months is not going to change what's happening in your body. It's not that sudden.
Mhm.
And it's really important to know where you are and to have the analysis and data to understand where you actually are so that you don't come for a surprise. You don't come into
Mhm.
your fertility years trying to have a child surprised about why it's not happening, right? Like you want the data.
Right. Yeah. Thank you for sharing that. I had no idea that that was where the age 35 originally came from. That
Yeah.
is, wow, mind blown right now. Yeah. So, which I hope for those of you listening, like, again, that's a sign of hope. But, like, so let's kind of lay this out is that so if somebody is, upper 30s, low 40s, like, if they're working with a doctor who is telling them, well, your age is keeping, you're not going to be able to get pregnant at 40, then at least get a second opinion or maybe even a third to understand, like, because at that point we do, like, potentially you could be going through early perimenopause,
Mhm.
but at the same time maybe you aren't, and so getting that, you want to take that step to really understand and take the necessary testing and all of that to get that full picture to see if it is possible, because there is a possibility.
Yeah. Yeah.
Hmm.
Absolutely.
Yeah.
Absolutely. It's and like we evaluate and like do the second opinion thing via chat on Instagram. So if anybody wants to reach out to us, please do. It's free, right? Like we'll look at your labs and be like, is there a possibility here or not? And what are we working with? And like I try to be like honest and upfront and just like give you my opinion quickly
Hmm.
because there is just no time to waste. And if you're able to like say, oh, that is actually what's happening, or oh, my body's actually saying it's done, then at least you can say, okay, if not this way, then what are my other paths to motherhood? And there are a lot,
Hmm.
right? Like
Hmm.
there are so many other options that you have that open up if you're open to just like accepting where you are right now and like, hey, that's just what's happening. Okay, like got it. Let's move on to what's next. Instead of like the intensity with which so many people approach their fertility is like, no, it has to be this way. And I get it. I totally get it. Like I get where that's coming from. And
Yeah.
just like if it like, especially for the women that we talk to in their mid 40s, if if that if that time has come to a close sooner than you anticipated, yes, there's going to be grief. Yes, there's emotions to process. And motherhood is not a closed off thing for you. Like you can still
Mhm.
become a mother. There's still lots of ways to get there. Just be a little bit more open-minded about how that is going to
Yes, I love that.
happen.
So, Dr. Aumatma, like, how can people be finding you if they want some more information on this, on either if their age is affecting their fertility or these recurrent pregnancy losses? Tell us.
Yeah. So the best place to connect is Instagram at Holistic Fertility Doctor. Um, my AI bot is very much on it with helping navigate that conversation in a way that's effective. And then I can step in and just like look at the labs and be like, yes, no, like it's way faster than me having to like type every single response. So talking to 100 people a day, it's a little bit easier if I get all the information, I can review it, and then I can like have a decision quickly or an opinion quickly to make it effective. So yeah, find us on Instagram at Holistic Fertility Doctor. And our website is holisticfertilityinstitute.com.
That's great. And I will include those links in the show notes for everyone to get over there.
Yeah.
So, thank you so much for all the work that you're doing. I know you are just so innovative in your treatments and out there speaking to all these families and couples. And I just really appreciate all this work that you're doing for fertility.
Thank you. Thank you. You too.
Yeah. And thanks so
We're,
much for sharing your expertise today.
yeah, you're welcome. Thanks for having me.
Be sure to connect with Dr. Aumatma. Her work is amazing. She has her own podcast, Egg Meets Sperm. Go on and check that out. You can find her on Instagram at Holistic Fertility Doctor. Her links are here in the show notes. Dr. Aumatma and I dove into some deep fertility topics here. And really, we just brushed the surface on a lot of these. But you should be walking away knowing that your body is giving you signs, telling you what it needs in order to open up the best chance at getting pregnant with PCOS. So, listening to this podcast is the first step. That second step is getting that individualized care for your specific needs. And if you have PCOS and if you are struggling to get pregnant and you are looking for a path to optimize your fertility health, you want to get pregnant, but you know that just moving forward, going through IVF before looking at your fertility health, just it doesn't sit right with you. And if you want to take that time to really invest in your health, to understand the root causes of what's keeping your periods irregular, what's keeping you from getting pregnant, you're willing to invest some time into optimizing your health, you're willing to invest your finances, and your husband is right alongside you saying, yes, let's do this for our future family. If that's you, then sign up for a free PCOS Fertility Breakthrough Session. That's where you and I are going to talk one-on-one about your specific needs. And I will help you figure out, okay, based on what you've been doing so far, what are these missing links to your fertility? What's keeping you from getting pregnant? And based on that, then I'll be able to share what's the single most important step you can take moving forward in order to get the best chance at getting pregnant with PCOS. You can sign up for one of those at drangelapotter.com PCOS. And as we wrap up here, I want to remind you that the information on this podcast is for informational purposes only. And the only way to get specific medical advice about your fertility is to meet with me on one of those PCOS fertility breakthrough sessions. And as we finish up here, I want to remind you that if nobody has told you this today, I want to tell you that I believe in you and I believe in your ability to have the best chance at getting pregnant with PCOS. I'll see you next week.